What if I told you for decades, medicine has been built around the average male patient? Our prescriptions, our studies, the way we treat patients in strokes and heart attacks. Not because anyone meant to ignore women, but because no one realized half of the picture was missing. In today's episode of the 260, ER physician, medical researcher, 2-times author, Dr. Alyson McGregor pulls back the curtain on the subject of women's health. From heart attacks to strokes that look completely different in women's health, how hormones change the way our bodies metabolize medicine, Dr. McGregor shows us how awareness is not just power, it's life-saving. Let's dive in.
I've been practicing for about 20 years now. And I love, everything about the ER and emergency care. I also have been a prolific researcher trying to figure out and add to the literature base of what we use, the evidence we use when we're handling acute care conditions. So right now I'm in South Carolina in Greenville. I also work as an associate dean at our medical school here.
You are also the author of Sex Matters, and I've personally read it. It is a great book, and it brings to light a lot of male-centric research and how it's impacted how we take care of patients. And I want to get into that. Like, what made you get into that? Like, what made you start to research this?
Yes, it's really interesting. So, when I first was finishing my residency in emergency medicine, so we're talking, like I said, about 20 years ago, I was always interested in women's issues. And so I had that sort of interest. And, as an emergency physician and as EMS providers, we see everything, right? So the entire spectrum of health and disease. So if it's possible, it happens, we are there at the front lines. And so I was able to understand that there's a difference. There's a little bit of bias in how we treat women. There's a bias in understanding women's emotional responses. They don't seem to have the best outcomes with medications. And I was just noticing this over my training. So I started to say, well, I, applied and received an appointment at Brown University as an academic physician. So I wanted to do research as well as see patients. And I thought, well, let me start to look at this a bit more. And I noticed that when I told people I wanted to research women and women's health, there was this assumption that I was going to do all the pelvic exams in the emergency department. And I thought, well, that's interesting. Why do we immediately go to the reproductive organs with women? And it was about that time that the cardiovascular literature was starting to showcase that women have different symptoms when having a heart attack. And I thought, okay, well, if women are presenting differently with having a heart attack, why is that the case? Is it because they are having a different form of heart attack? Is it because differences in how their heart is actually undergoing this pathology? Or is it how they present? Is it just sort of a societal, cultural reason? And so I started to really look into that. And then at that time, they were really talking about women having atypical symptoms of heart disease. And then I started to realize that it's because women have different ways of having a heart disease, as well as presenting differences. So, we were taught through medical school and throughout my residency training to look for male pattern of illnesses. When I look at my medical textbooks, I'm sure you can look at your textbooks, it was really filled with male photos, male images, male patterns of heart attack, a male sort of clutching their chest and rating to the left arm, and emphysema and COPD, or the men that are there, all these images. And then there were just images of women's reproductive organs. So I was really researching how that affects the whole spectrum. So stroke and sepsis and trauma and things that happen during pregnancy. So it's been really, really interesting to be part of that movement of like revealing the fact that men and women are different in the whole spectrum of health and illness and disease.
The one thing I found interesting, like reading your book, was how when we do science, like when we research these things, how much women are cut out. And some of that was because of the whole finding babies, right? And, doctors were initially, they were men first. So obviously, like, what do doctors do? They study other doctors, right? And practice on each other. And that's what really created a lot of these biases or this misinformation that women are just different. Like, our hormones are different. Everything is different. So that's the reason why I really loved your book was like, yes, like, we are different. You're very different. Can you
Yeah.
talk about how our heart attacks are different?
First, I just want to comment that it goes way back to even just our understanding of science. Like when high school biology class, for instance, if we think about that, right, we're taught that the sperm and the egg get together and they decide whether you get XX chromosomes or XY chromosomes. If you're XX, that makes female, and if you're XY, that makes a male. And those will then develop testes or ovaries. And then the testes or ovaries will either regulate testosterone or estrogen. And then those things will develop secondary sex characteristics. So males will develop hair and have deeper voice, and women will have breast development. And that was it. That's the end of the story of those chromosomes. And so, without realizing that those chromosomes are in the heart cells, they're in the lung cells, they're in the brain cells. We have receptors for estrogen and testosterone all throughout our body, even our immune cells. And so this concept of it just being that sort of one step of creating reproductive organs, and then that's it, that was a generally acceptable concept. So then we started having this understanding of evidence-based medicine and doing clinical research. And during that time is when the example that you brought up with thalidomide, where women were taking this medication, and if they were pregnant, it was, creating some really horrible birth defects. That's when it was like, okay, let's stop studying women. It may not matter anyway, because men and women are alike in every other way besides their reproductive organs. And then we can protect them from having any abnormal effects during pregnancy if they get pregnant during the study. So that's when we really just focused on men. And you're absolutely right. We studied male physicians. The Physicians' Health Study started with looking at 20,000 male physicians, and that became our understanding of heart attacks and heart disease was based on that cohort. And so that's where sort of our understanding of everything. We started to create medicines around it. We started to teach all of the healthcare providers about that. All the public health sessions were really about how males develop heart attacks, develop disease, and then how to treat them. So a lot of differences that we know now, because we've really sort of evolved, and it's taken very slow. It's very long, because the NIH said, I think we're having some understanding that there's differences between men and women. And they really said that in order to apply for funding for your research project, we really want to make sure that both males and females are enrolled, and then make sure that you analyze the study differently. So in other words, you can't just take 50 females and 50 males and then combine them, because sometimes something might happen in a female that's positive, and then it's be negative in the males. And if you combine them, you won't see that result. So it's really about studying men and women and enough to separately and then compare those differences. So since we started doing that, we realized that not only do women present differently when having a heart attack, they might have chest discomfort, but they don't describe it always like an elephant sitting on their chest. They have more fatigue for days to weeks. They're nauseous. They have dizziness, lightheadedness. These are very vague presentations, as we all know. It's very hard when a woman says, "Oh, I just don't feel right." to then think this could be an acute heart attack. It's not part of our training. It's not part of your training. And so that's one of the major, I think, differences that we can really embrace is that, just to be more aware of women presentation of symptoms. And then we're realizing it's because the way that they develop disease is different. So the coronary arteries, we're taught that the large artery develops plaque, because you have diabetes, you have high blood pressure, and then that will create a clot and you'll have an occlusion. That's a MI. We all know that. That's a STEMI. Hurry up, get to the cath lab. That's what we were taught. But women develop disease in a different way. They develop microvascular disease, so smaller arteries. The way they develop plaque is different. The way that if you have a heart attack and the way that, heart failure gets developed is different. And that's because of those coronary arteries and those heart muscle cells have XX in them versus XY. They have receptors for estrogen instead of all that, flooding of testosterone. So all of this is now really, really fascinating. It's an exciting time to really embrace the fact that women develop disease differently from men, and so they'll present differently from men.
That's so interesting and cool because as just listening to you talk, I can think of one hand, the individual males I've had who were symptomatic of some sort of cardiac event and they were atypical, like not often, but it seems like all of the ones that come into my brain, they're all female. I don't know, like a lot of the men were pretty kind of like what you talked about, like, it was the stereotypical things that they put in your books or whatever, but it is not uncommon at all for females to have, I don't know, just these kind of, for lack of a better term, like kind of off the wall, vague symptoms like my leg hurts or I just feel strange or,
Yeah, that's what, like I said, again, I'm just going to be referencing your book a whole lot, but like talking about your book, when I was like reading it, I'm like, man, like I'm sitting here thinking of all the patients I've had where I was always big in doing like a head to toe and how many things I caught doing the head to toe, like they weren't complaining of chest pain, but hey, I caught an MI, or they weren't complaining. They were like, I just feel off. Oh, their blood sugar's low.
Right. Exactly. And that's it, because we're taught pattern recognition. We work so hard in our education, our training, to recognize patterns. This is what a stroke can look like. This is what a heart attack can look like. This is what sepsis. And I think, one of the most important things about, field providers is you're getting much more opportunities to treat on the field, right? Because time is so important, it's so essential. And so that's where it's really critical, because now you have the opportunity to think and say, oh, wait a minute, what's typical has really been very male-centric. So instead of thinking of women as like atypical, it's very typical for women to present that way. It's just we have to sort of, update the way that we have been formulated our brain. All that work that we did for those patterns now just have to evolve to new evidence. And that's part of being in medicine and science. It's humbling. As soon as we think we've figured something out, it changes.
And that's one thing
Yes.
that I do very much appreciate that you mentioned in your book, was that every body, male or female, needs to be studied uniquely and treated uniquely versus everyone being the same. I like natural medicine too. And when I dive into that stuff, I'm like, man, like we treat like the thyroid. The thyroid gets blamed for a lot of stuff, but is it really the thyroid?
Yeah. I think that by not studying women, we have a very poor understanding of autoimmune conditions. All those syndromes, irritable bowel syndrome, fibromyalgia syndrome, chronic pain syndrome, all these autoimmune conditions, it's really because we haven't studied them very specifically. So when studying men, if those things aren't very common in men, then women presents with like, oh, this hurts. And then, I know that people can't see me. So like my shoulder hurts, my toe hurts, I feel short of breath. It's hard to put all that together because we just haven't really studied specifically women conditions very well. And so I think as we evolve, we'll really start to understand more and more, what are the specific conditions that women undergo, instead of, yes, blaming it on the thyroid, because thyroid affects so much of the body that it must be involved in it. And it may be, but it's more complex than that.
Kind of going back to cardiac, before I forget to ask this question, does the 12 lead look any different for women?
Yes, it's a great question. And there's a lot of subtleties out there. And I've looked this up and tried to really concentrate on some of those differences. And every aspect of the 12 lead can look different in general, if, different patterns based on males and females. A STEMI is still a STEMI. One of the things that I think is most unique about the differences is the QT interval. So women have a longer QT interval, and they're on more prescription medication. So many prescription medications will prolong that QT interval. And so they already have a long one to begin with compared to men. So we worry about that causing torsades or some of these fatal arrhythmias. But there's subtleties in the P wave and QRS and T wave that are, that on average are different. But from a very emergent and urgent standpoint, the basics will be there. But heart rate variability, those types of things we're starting to learn are subtle differences between men and women.
Well, we have you mentioned the subtle differences between men and women and 12 leads. You mentioned sepsis a little bit ago. I'm curious if there are any stark differences that come to your mind that you've observed between male and female presentation.
Yeah, I think that, again, a lot of this is so exciting and so new. But when I think of sepsis, and the differences, sex differences in sepsis, women have a much more robust immune system. And that's why women have more autoimmune conditions, because there's like the button that gets turned on, like, oops, there's an infection, is sometimes overdone. The alarm is like really set off. And so that's where I think women have that sort of susceptibility. So they may present earlier or have much more, because of that robust response, it might be more susceptible to either hypotension or earlier tachycardia. I'm not entirely clear on that particular piece, but the incidence of that is important. And I think what happens with men is that they don't have that response as quickly. And sometimes that's beneficial, sometimes that's not beneficial. Mm-hmm. For instance, in COVID was a really interesting because of men. Sex differences research, is a lot about women because most of our knowledge base is already in men. And so we have some catching up to do. But what happened with COVID is that the incidence of getting the infection was about the same between men and women. But men were more likely to become septic, to more likely to go to the ICU and have higher mortality rates. And part of that was thought to be due to the fact that men have less of a robust immune response. And so that was one positive thing for women, is that it was ready to go. But then also testosterone really increased the receptor response of COVID in men. And so there was some really interesting data that was showing how the sex differences really put men at poor outcomes. Which just shows that this is just good research. It's just good knowledge. It's good for both men and women when we start to think about these differences, because we'll ultimately have more, precision care. Like we said before, it's just we treated, like you mentioned, everybody the same. Now we're really going towards, we thought like we can have really precise medicine, but we have this major first step. Is in, okay, are you male or female physiology? Because that's the first step that's going down the line. So other things regarding sepsis are which types of infections. Women are more likely to have urinary tract infections. Those types of things have to do with anatomic susceptibility, environmental susceptibility, those types of things.
What about strokes? You mentioned strokes are a little different for women too.
Yeah, it's very similar. Just like with, when you think about heart attacks, when you think about it's because of the blood vessels, That's similar with stroke. It's, we're taught a lot of the classic signs are the, hemiparesis, half of your face is paralyzed or your body. But the same thing occurs with women where it's not as typical. So it's not as like typically when we think about. So women will have headache. And when I was taught about stroke, it was like, oh, stroke doesn't hurt. So, with women coming with a bad headache, so that's something that we've learned. It's much more dizziness, much more that same sort of lightheaded, vertigo, dizziness, headache. That's more common in women's presentation. And women are more likely to have migraines, which tends to be risk factor for stroke, things along those nature. One of the studies that I was involved in, we looked at men and women coming in with acute stroke and who were more likely to receive the clot-busting drug. And it was men. So women were less likely to receive it. And then we started to look at why. And part of that was because their symptoms weren't as straightforward. And so that sort of delays that sort of diagnosis, and then they're outside the window, that sort of thing. So, it's just kind of interesting to look at all of these different parts of it.
So because women have strokes in like their smaller vessels, they're just having headaches and we're missing that versus the big vessels?
I think that's a great way to look at it. I think it's all multifactorial, and I think it has to do with also hormones. I know that Dr. Tracy Madsen, she's an emergency medicine physician, and she's a very great researcher on sex differences in stroke. And she's come up with amazing differences, including different biomarkers that have to do with female sex steroids. And so it's really starting to come to light. It's hard to make it so specific to say, okay, now you have to look at this. I know with, field providers, it's very much, these are the things to look for to then do this next step. And I think it's really important for everyone to realize that that's not really, there's gray to all of that. Because, we learn and have to evolve. So just to have a really sort of open mind and be more suspicious about presentations, especially in women.
So out of curiosity, what would, like if you're in my position, you're going out to someone's house, they're complaining of a headache, at what point are you going to sit there and think, this is a stroke, this is not just a regular headache, or be suspicious of it?
What we do, like in general, when we think about what's a bad headache, what's a headache to worry about and it's worth working up, it's of course acute in onset, because that sort of tells you that there might be something vascular or something more catastrophic going on, and it's looking at the whole picture. So if someone has lots of risk factors, keeping in mind those sorts of things that would create more of a concerning headache, like a subarachnoid hemorrhage, or the start of a stroke, gestalt that you have to have when you're evaluating patients. What are their vital signs? Are they on any blood thinners? Do they have any focal neurologic findings? All of that stuff that you've been trained is still very much pertinent, but it's also just having a little bit more of that understanding that this, may not fit the perfect scenario that you've studied, especially if it's a female patient.
So we gotta keep an open mind, maybe not exclude that in the differential diagnosis quite yet. We can't maybe rule it out. Let's leave that in there and maybe treat it as such potentially until you get more information back. I mean, we're very limited in what we can do in the pre-hospital setting, but that makes sense. I mean, yeah, exactly. We gotta open up our mind a little bit and have some patience and yeah.
Yeah.
And there are risk factors that are specific for women that, the American Heart Association mentioned years ago, and it actually just finally entered into the stroke risk factor literature. But one of the things that you can do to assess the risk of a woman is to ask if they've had pregnancy complications. So preeclampsia, gestational diabetes, hypertension associated with pregnancy. Those things are risk factors for heart disease and stroke. And for some reason, we just don't teach to ask those. So I teach, my students and the residents to ask those. If you have rheumatoid arthritis, that's a risk factor for heart disease and stroke. And so there are what we call sex-specific risk factors that are specific for either men or women. And so starting to include those into the questions that you ask will help you gauge whether or not bring the patient in, license sirens, or just help them up. There's a lot of that. That's a lot of decision control that you have. It's you're triaging a lot of times whether the patients seek further care or not, and that's a lot of power. And so I think it's so great that with this podcast that you're continuing the conversation for all your listeners, because these are the types of things that we want to continue to add to our questions that we ask and our assessments.
Yeah, I love that. That's I love OBGYN stuff. So with my recruits, I always say, you can have complications up to a year or even a little bit past. So, that's great that we're mentioning that. It's great to ask those questions. Always ask. You're not going to offend anyone by asking about their medical history.
Yeah. I wanted to, since we're bringing up pregnant patients, is there any stark differences in your research that you've noticed between women and women who are mothers specifically when it comes to cardiac workups, stroke workups, sepsis presentation, pneumonia, anything? Just open the book up. But the big difference being women and women who are mothers specifically.
I think that's an interesting question too, because if we think about that, maternal mortality is cardiovascular. The number one cause of maternal mortality is cardiovascular disease. It is a stress test for the heart. Mm-hmm. And so we don't think about that like that. And so a lot of times, one of the reasons why complications during pregnancy is a risk factor for future heart disease and stroke is because it either initiates a sort of spiral of heart dysfunction, or it uncovers it early. And so when we were taught that who has heart attacks and strokes, we think men, and we think postmenopausal women, right? That was it. Women are protected from heart attack until after menopause, but that's not accurate anymore. And so what we really need to be aware is that young women have heart attacks and strokes. And so that's a switch in our sort of understanding. So if you have a young woman, especially one that has that is a mother that has given birth, they could have higher incidences of heart failure. And so I think that's important to consider. And that's why the conversations that you ask. Also, women who have had pregnancy or postpartum, there is no specific cutoff. We say it's 4 to 6 weeks is postpartum, but that, it depends on that mom's physiology. Her risks of blood clots and preeclampsia and these things still continue on. And so there's a lot that changes with undergoing pregnancy that puts people at risk for, a lot of these more serious conditions, including PE and stroke and heart attacks as well. So keeping that in mind, I think, is a great point.
I want to talk about some pharmacology stuff because I thought, again, back to your book, this was so interesting finding out about generic meds and the filler that they use for generic meds. You mentioned that women tend to have adverse effects to that and have symptoms based off of that. And I thought that was so interesting because I'm how many times have I looked at someone's med list and they're like, oh, I feel weird, I feel off. And I'm I could have been hey, it could be this med. You just change to it. It's a generic med.
Yeah, right. Because again, I think, this, I don't want to sound negative because I think it's really positive. But again, there's a party line, healthy questionable curiosity is good. So for instance, I was always taught that, generic meds are the same. And so when I would see a patient and then they would say, oh, I don't feel good, maybe it's because my blood pressure medication just got changed to a generic. And we were taught to say, oh, that's not it, or that's in your head. Or so when you do a deep dive, you realize that there's the way that a generic med gets approved is it's a bioequivalence. That's not the same. The active ingredient has to do what it's supposed to do within a certain range. So not exactly. It's like it could be 20% less effective or 20% more effective. But if you think about it, and so they compare that to the original medication. But if you think about it, that original medication was primarily tested in male subjects. And so that's the first thing. So it's so who knows, how a female patient would necessarily responds to that. And then for that to change formulation has to have the active ingredient, but then it can use any other types of fillers. And then that has a much shorter testing on primarily male subjects. So it just has to show very, very simple studies that it does sort of what the active ingredient does, and then they test it mostly in men. So it just sort of even blinds the downstream understanding of how that medication might affect women even more. And so I think that is just having that realization and telling your female patients that they may not feel good. It may not feel the same. Is critical for their own sanity and for their own ability to then navigate their healthcare. Because I think the medication responses and the differences between men and women is incredible. Ambien is a great example because Ambien is, a sleep medication. It was primarily tested and approved in men. Women are more likely to be prescribed it because they have, say that they can't sleep more often than men do. And so for 20 years, women were taking the same dose as men and then waking up in the morning and feeling groggy and then getting in the car and then getting into a car accident. And so what happened was we looked at that, not we is the general we. It was looked at and they said, okay, well, let's give Ambien to men and let's give Ambien to women. And then we'll test the serum concentration after 6 hours or so. And they found that women had 2 times of the serum concentration left in their body active than men because men were metabolizing it quicker. Now the FDA says, okay, well, women should be given half the dose than men. I think that's amazing. And it's that type of specificness that we should be doing between men and women. So when I see patients, women in the emergency department, I see that they're taking Ambien and I look at the dose and I see they're on the male dose. I look at that as an opportunity to have that conversation with them that perhaps that they could have a lower dose and still sleep and have a safer effect. So that's one prescription medication that we looked at differences between men and women. And there are 20,000 prescription medications that are approved by the FDA to be prescribed right now that haven't looked at differences between men and women that have been mostly studied in men. So it's an eye-opener. It's an eye-opener. And I think one of the first things that we could all do is stop telling women that this is all in their head, start to realize that these symptoms are real. They're just vague and we're not used to figuring out what they all, connecting them all and what they all mean. Yeah,
the other thing I thought, and this came from someone that I know personally, this individual, she was taking some anxiety meds, and she, depending on the time of the month, was depending on how effectively they worked. And I thought that was interesting.
Absolutely.
Yeah.
We haven't looked at what how the menstrual cycle affects metabolism. People who have seizures, seizure medication is one of those that changes based on the menstrual cycle. And so a woman could be on a medication, and then she's on the certain part of the menstrual cycle, and then it goes to a level that's not preventing a seizure. So she has a breakthrough seizure. And then, they call EMS, you bring her in, and what do? We increase the dose. but she only need that increased dose for like 4 or 5 days. So it's not only tailoring it based on whether you're a man or woman, it's tailoring it based on the woman's cycle as well, I think is something that's soon to happen. And I think with all the technology, AI and apps, those are things that we should be able to do very soon.
The other thing I want to mention when coming to pharmacology is pain meds. And in your book, you talk about how women experience pain differently. We experience it sooner than men, but we also have a higher pain tolerance. Is that correct? Or a lower pain tolerance?
I'm going to say yes to all of that. Yes, and because it's really complicated. There's some amazing research out there on the sex differences in pain, and it's extremely complex. And I always try to put it together for like a sound bite, and then it's very contradictory. What we do know is that the pain pathway between men and women is different. So if each of you, it's good because we have we have both samples here. So if each of you were to, cut your arm right now while we're talking, the signal to the brain uses different pathways if you're a male, if you're a female. This was totally not understood when we made morphine and oxycodone and Dilaudid and fentanyl, right? So who knows if those pathways of all the medications that we use act the same way, because they were mostly made and studied in men. So you can kind of see this is the problem, the pattern is that our understanding of medicine has been based on the male model. And so women might not have the same effect. And so, again, just with metabolism of medications and things. So women are more likely to start having nausea and vomiting when given the same dose, or more likely to have respiratory depression when given the same dose. And I think also if you think about social, cultural, gender differences, women are often tearful, because society, it's okay that for women to express emotion, and men are less likely to express emotion in that way. So we think men are more stoic. If women are tearful when they break their arm, we think they're anxious. And so we give them benzodiazepines when actually, they're just tearful because they're in pain. And so there's a lot of cultural differences that are involved in pain, and a lot of neurochemical differences. It's really sort of a fascinating area.
Yeah, also, like for me personally, I absolutely hate receiving pain meds because I don't feel good after them. Like I always say, like Toradol, like low dose, like if you're going to give me anything for anything, like because I normally end up throwing up. And I remember I picked up this lady who, she broke her hip. It was obviously broken. And I wanted to give her something. And she's like, absolutely not. She's like, I always throw up. I never feel good. I'm like, I can give you Zofran. And she's like, no. And I'm like, you know what? Okay, I'll honor that. If it gets too much, I will give you something en route. But, she's like, I'm cool just holding your hand and yelling if I need to yell. And I thought that was interesting. You mentioned that in your book, too, about how women, again, like they just don't feel good with meds. Pain meds specifically.
Yeah, I mean, exactly. Different ways of metabolizing it, and bravo to you for allowing her to have some governance and you being a good listener.
Yeah, I feel like in my limited experience, it's women have I think they just have a higher pain tolerance. Like from all the traumatic injuries I've seen, it seems like men are usually the ones hooping and hollering.
Yeah, well, I think that's I know with the traumatic ones, but the man flu. It's funny to sort of pull some of these things together, but they've actually studied the man flu, and there's some physiologic evidence-based reason why men complain more. So, I think it's just really interesting type of literature.
In your experience controlling pain in your female patients, what do you have like a first line where you're like, you know what, I'm going to start with this as opposed to this, or anything like that, or not particularly? It's an individual based, or
it depends on what the etiology of the pain is. So what is the pain? Mm-hmm. If it's a headache, then I think of different things for the brain. But in general, if I were to just say something for all of your listeners, it would be dosing. So even if you consider the same medication for both men and women, just stop and consider the dosing. And now, in general, it's not always less for women, but in general, that's a good place to start. Some medications are lipophilic, so they distribute themselves into body fat, and women have more body fat and have more muscle. So that metabolism may change. There's lots of all of these things. So just if you think about it, I would say just be careful and go slower in dosing than you would in women than men. It's a general rule, that I think is safe to follow.
I appreciate that. Thank you.
Yeah.
Yeah, so I don't want to take up too much of your time here. I want to know, what do you think the future is going to look like when it comes, as you're doing this research? Because you're heading all this research. It's once you learn this, and you've said this multiple times, once you learn it, it's hard to unlearn it.
I think this is heading in a direction so we have to consider AI sort of driving some of this bus. And I just had this thought recently, because when I was in school, my smartness or my intellect would be measured on my ability to recall, right? Memorize. We would get pinned, right? What are the 5 signs of this? Or what is, what are the most likely complications of this? And you'd have to memorize all of these, this recall. 20 years later, there's so much to learn. It just keeps getting larger and larger and larger, right? So it's not really about recall. It's about knowing what resource to look it up. And so that's been very helpful to realize, and, just evolving with kind of the science. So when I think of that, I think of, okay, well, if we're asking AI questions, if my patient presents with these symptoms, what should I be considering? That's going to look at the database. Right? And so, one of the things I've always been concerned about is the database being biased, because our data is based on only half the population. But I think more and more of this evidence is really coming to light. And over the past decade, we're doing a lot more research on sex differences and understanding these things. The slowness is how to, a researcher finds something really interesting, like the Ambien, publishes a paper. How does that get to the educational piece of training EMS, training nursing, training doctors, so that they can update that to prescribe? That takes a long time, right? To be able to fix all that. But I think if we're going to AI and we are just using this intelligence to look at the data and then have that data now be up to date quicker, I think it will speed the translation to patient care. That's kind of my latest observation, and latest hope, basically. I think the future is bright, it's positive, it's humbling, and we just have to continue to evolve and use our sphere of influence. So you two are using your sphere of influence with this podcast, which is great. So it's just awareness of these, this sort of different concept of medical care.
How about to the discouraged clinician? It could be pre-hospital, it could be in hospital, but someone who maybe you're motivated by this information and you're pushing the stone the correct way, and you're gathering all this intel, and it's beautiful. But say someone's just discouraged by this information. They're this isn't, I don't know, what am I really doing here? What would you tell them?
I had that problem a lot in the beginning, because when I was mentioning that this might be an important feature in patient care, the first kickback I would get is, oh, you're telling me I'm doing something wrong. And I was like, no. Now I feel like it's really sort of evolved and to this understanding of, if you're in this field, then it's important to stay up to date, right? It's not like once you graduate, you're done. In medicine, that just doesn't exist. If you're involved in patient care, science, that's unfortunately, it's a lifelong learning commitment. right? Because we're constantly learning new things. So it's a tough job to get into. So I would say it's not anyone's fault. No one really did this deliberately. The early research and scientists were both men and women. We all just didn't realize how important these differences are. And so I would say to look at it from a different perspective of just evolving science and to embrace some of that. It's very humbling. And yes, of course, it's very frustrating because most of us go into this to really have a positive impact on people's lives. We find an element that we really like. Emergency medicine is our crossover, which is really beautiful. And so I just think that it's thinking of it in that way, I think, would be a much more positive aspect to sort of concentrate on.
Yeah, that perspective, like you're a part of the future, and the future is accurate.
Yes.
That's what I
That's
like.
cool. Yeah, that's cool. I like that.
Well, Alyson, is there anything else you would like to share with EMS about women's health before I end it here?
No, I just like to end with that sphere of influence concept, which is, whether you are teaching recruit, whether you are talking to your own doctor, and wanting to share, like, how does this medicine you just prescribed differ if I'm a male or a female? I just learned something, like, what do you think? People may not always know the answer, but I think it will prompt them to consider it and sort of look it up. And so, I think just continuing to create awareness about this without, in a positive way will help create change that we need, in a quicker. And just good luck to everybody. And thank you for all the hard work that you do. My father and my brother are police officers. And so I think that's why I really liked going into emergency medicine, because my dad was in a uniform and really, on the front lines. And my brother was sergeant at Providence Police. And when I was finishing my shift, he would pick me up on his night shifts and I would ride along with him. And wow, it just, being out there with the patients in their spaces is a whole different thing. And I just really appreciate the skill and the work that it takes to do that well. So thank you.
Well, thank you for your research, for speaking out. And I'm linking your book below in the show notes. I encourage everyone to go read it. It is a good read. Like we always say, leave it better than you found it.